So, good evening, friends. With the permission of the faculty here, let us start the PG clinics. I think this is the last clinics for the year. We had a glorious start and happy to share. We have close to 1.29 lakh views so far. I'm sure students have been benefited for the contribution. I would say relentless contribution by all the faculty who have been joining us at various things and all the faculty who have been with us all through from the time of inception. And I'm sure all of you had a very good National ASICON deliberation. We had a, by and large, I was told it is 4,700 papers, the largest ever paper numbers received for free and award papers for the National ASICON. So I wished all the students very well. And I wish you Merry Christmas and Happy New Year for the faculty and the residents who have been joined with us in the Zoom and in the YouTube. And we have invited faculty, Professor Rajan Patel, Professor Somashekar and Professor M. Rajashekar will be shortly joining us. And we warmly welcome our senior faculty, Professor Kanna sir, Shanai sir, Srinivasan sir, Andariya sir, Ishwar sir. I think we have more faculty here. We have Selvaraj sir, chairman of the ASI Tamil Nadu has joined. We have, welcome sir. Congratulations for taking over as chairman TNSI 2022, sir.
Thank you, Dr. Kanaivel. Thank you very much. Thank you.
Thank you, sir. And
so how are you?
Sir, all of us are very well, sir. We need your blessing, sir.
Good. Okay.
And we have, this is Dr. T.T. Selvaraj. He is from Tirupur. He is the chairman-elect for the Tamil Nadu ASI chapter for the year 20. Right now, chairman-elect for 21. He will be the chairman for 22, sir. Welcome, sir.
Yeah, and, sure. Thank you. With all your support, I think we'll do something good.
Yes, sir. Yes, sir. And, we have Professor Guru Shantappa, Professor Sridhar Lingam, sir, and many other senior faculty. I warmly welcome. I also request them to kindly contribute for the welfare of the classes. Today, we have two important cases to be deliberated by the students. One is given by Dr. Ishwar sir from KIMS, and the other one is from Dr. Shanai sir himself from KMC Manipal. I'm sure today we are going to have two abdomen cases. Both are different areas, mass abdomen. So I'm sure today's students will be benefited by handling mass abdomen in a go. So we are going to have the spectrum of clinical finding, spectrum of presentation, and the diverse management to be discussed in the coming 2 hours. So I would now welcome the Dr. Rasana to share her presentation, introduce herself, and then her moderators, and then start the presentation. Over to you, Dr. Rasana. Good evening, Dr. Rasana.
Good evening, sir. Good evening.
I just 1 minute. So I used to call her as a Rasana. She's actually Rasagna.
Rasagna. I'm sorry, sir.
But
like our Gujarati name. This is more like our Gujarati name.
Is it?
Yes, she has origins from your state, sir.
Okay, right. We'll start, sir. Yes.
Rasagna, over to you, ma. Carry on.
Yes. Good evening, everyone. I am Dr. Rasagna, final year PG from Kasturba Hospital, Manipal, and I am presenting a case presentation today under the guidance of Dr. Rajgopal Shenoy, sir. Mrs. X, a 65-year-old lady, homemaker, hailing from Udupi, Karnataka, a known hypertensive, presented to the hospital with chief complaints of pain abdomen since 6 months and abdominal distension since 1 month. Patient was apparently normal 6 months ago when she developed pain abdomen, which was insidious in onset, gradually progressive, predominantly in the lower abdomen. It was intermittent in nature and dull aching type of pain. There was no history of radiation of pain. There was no history of association of pain with food intake. There were no aggravating or relieving factors for the pain. It was also associated with abdominal distension since 1 month, which was insidious in onset and gradually progressive. Patient gives history of fever since 6 months on and off with evening rise in temperature, and it was not associated with chills. History of weight loss present, but however, the patient could not quantify the weight loss. No history of vomiting. No history of constipation. No history of altered bowel habits. No history of melena. No history of loss of appetite. No history of yellowish discoloration of eyes. No history of cough or breathlessness. Past history. No similar complaints in the past. No history of diabetes, asthma, ischemic heart disease, or tuberculosis in the past. History of tubal ligation present, which was done 20 years ago. There was nil significant family history. Patient consumes mixed diet. There is no history of loss of appetite, no history of bowel or bladder disturbances, no history of alcohol consumption or smoking. Menstrual history. Patient attained menarche at the age of 13 years and she had regular cycles, and patient attained menopause at the age of 52 years. Based on the history, I would like to give a provisional diagnosis of abdominal tuberculosis or carcinoma ovary. General examination. Patient is conscious, cooperative, oriented to time, place, and person, moderately built and moderately nourished. There was pallor present, no icterus or no generalized lymphadenopathy. Vitals. On examination, the pulse rate was 80 beats per minute, regular rhythm, normal in volume, in right radial artery in supine position. Blood pressure was 130 by 80 millimeters of mercury in right brachial artery in supine position. Respiratory rate was 18 breaths per minute and patient was afebrile at the time of examination. On examination, coming to local examination, that is the per abdominal examination. On inspection, there was fullness noted in the lower abdomen and in the flanks. All corresponding quadrants were moving equally with respiration.
I think we should stop at this stage and ask history of all those complaints and the history, etc. Sir,
Yes.
Hitesh or Ajay Khanna, sir, please. She's our my candidate, so please go ahead with the questioning to her history, sir, history, etc.
We have
Can you
Professor
go back?
Rajasekhar also
Ah, yes, sorry.
from
Yes,
Salem, and we
yes,
have Professor Rajan Patel from
correct. So,
HL Medical College, and other senior faculty can also ask. Please take over, sir. Please.
Dr. Rasagna, why
Yes.
did you keep your possibility of the Cox abdomen here?
So patient had come with a pain abdomen, which is history since 6 months, which is a long duration. And also patient has a history of abdominal distension, and associated patient also gives history of fever along with history of weight loss. So all these tentatively point towards the diagnosis of abdominal tuberculosis, and predominantly in India where tuberculosis is still common.
What is your age?
65-year-old ladies.
Do you think the 65 is the age for the tuberculosis?
No, sir. It generally not, but due to the history of abdominal distension and the history of fever and history of weight loss.
And you can say other symptoms are not there which correlate with the other diagnosis.
Rules out other diagnosis. Yes.
And in our country, we cannot rule out tuberculosis. This is what you have to argue.
Yes.
Why did you keep the ovarian tumor as the second diagnosis?
So because it's a female patient and elderly, and patient has predominantly pain in the lower abdomen and also abdominal distension and weight loss, which can point towards a malignancy because of the weight loss and the distension.
So one question which Khanna sir asked you, why not carcinoma, ovarian malignancy first and then tuberculosis? What was the reason to keep?
Patient has history of fever. Fever I cannot explain in a ovarian malignancy. And it can be explained with the diagnosis of abdominal tuberculosis.
And what was the type of the fever here?
The patient had occasional fever on and off once in 2 or 3 days, predominantly in the evening. But there was no history of any chills associated with the fever.
But in the if it is a tuberculosis is there,
Yes.
do you get intermittent type of the fever there, miss? Every 3 or 4 days it will come?
Fever will be continuous, sir, predominantly in the evening.
It
with
will be every
heating
day.
raise of
It
temperature.
will be every day, and it
Every
will not
day.
be at 3 or 4 days.
Hello. Secondly, you start your history with the patient is a known case of hypertension. Why you start that? What is the inference you want to carry forward in your chief complaint or associate the hypertension with your history?
No, sir, there's no association of hypertension with the history. I just wanted to tell the pre-morbid condition.
Can be a past history or a anything else rather than a chief complaint. You should not mention this thing. What I feel so.
Yes, sir. Yes.
See, what Dr. Rajan Patel told is perfect. See, if it is a carcinoma breast, no doubt you can always tell premenopausal lady or a post, because there is some relevance in that. Relevance.
Yes.
Probably some sound is heard. I don't know where it is. My question to you is that just can you enumerate 3 or 4 conditions of abdominal mass and fever? That's what is. This is how you try to analyze the whole story
Yes.
now. Can you just enumerate few causes like that?
Abdominal mass and fever, sir.
Because your complaint is that pain, abdomen, distension. Okay,
Yes.
this kind of a scenario.
Yes, sir. If it is an acute condition, if it
No,
is
no,
a
no,
shock.
no, no.
This case.
We'll
This
not
case.
bring. We will only talk about our patient.
Yes, sir.
So one is tuberculosis, which everyone knows for
Yes.
some. And what are the other possibilities?
One more condition will be a lymphoma, sir. Either originating from the
Common in this group? What type of lymphoma?
non-Hodgkin's lymphoma will become.
Non-Hodgkin's lymphoma will give you abdominal distension like this.
No, sir, but it predominantly affects the extranodal organs, I mean, sites than the lymph nodes predominantly.
What
It
you
will affect-
the question which is asked to her was that what are the reasons of abdominal mass and fever analysis? One is no doubt distension, tuberculosis is one. If it is a lymphoma, maybe why did you tell non-Hodgkin's? Why not Hodgkin's? Simple example. Lymph
So
nodes, liver,
most-
spleen. Yes.
It can be Hodgkin's lymphoma also, sir. But the most common site is cervical lymph nodes. But other, it can affect the.
No. It is not like that. Hodgkin's can occur intra-abdominally, intrathoracic also.
Yes.
So it's not true.
Can you name 1 or 2 tumors in the abdomen which can present as fever? This is how you should heard about ascites and all that. Now, I just want you to try to think in that. Some tumors. They will also have 3 months, 6 months loss of weight, loss of appetite, weight loss. Can you think something in the liver?
Yes, sir. Any hepatocellular carcinoma can also have history of weight loss and fever also.
And any other condition in the abdomen? Something in the loin? I have given you a clue. Yes. You need to know this.
Yes, renal cell carcinoma.
So some of the things you need to know that renal cell carcinoma, you need to know hepatocellular. These are broader way of analyzing. And last, my side, one question is why that evening rise of temperature in tuberculosis? Sir, for the benefit of all of you, sir, I have not discussed anything about this case to Vidar. These are the questions which I wanted everyone to understand.
Yes.
Yes, sir. Yes, sir.
Problem.
We fully know you, sir, now.
No, not that. What is the cause of so-called the evening rise of temperature?
You can explain, sir, please.
That's
the way she...
body rhythm itself is relatively more in the evening, number one. Number two, as you go in the evening, even the hormonal changes happen more in the evening. Tubercular toxins are also supposed to be released late in the evening, and you feel awareness rather, of all the symptoms. That is explained. If anyone knows other, please go ahead.
Even a normal person is more fresh in the morning and tired at the end of the day, by and large. So these all factors contribute.
Guru Santapa, sir, you can ask the question, sir. Type chat, no box will see. Please, sir. Guru Santapa, sir.
Yes, sir. Yes, sir. It's all right, sir. Shanai,
You
sir,
ask,
will see those
you ask,
questions.
your,
and
you
just-
ask, sir. Chat box, no one will see. She
Sir,
will
Guru
answer.
Please
Santapa.
ask.
Yeah.
Please,
okay.
sir, ask.
Sir, good evening.
Yeah.
Good
Good
evening,
evening,
sir.
sir. Good evening, sir.
You ask
How
the
are you?
question.
Yeah, what I wanted to know, if you are on history-wise, because I think she was not stopped at history and stage when she went for examination. At history level, doctor, if you think it is tuberculosis, what is the first possibility? Is it a peritoneal or involving the intestine? Which
Intestinal.
one you are thinking in terms of, if it is tuberculosis?
50,000 நாளைக்கு கேட்டாரு 50,000 நாளைக்கு கேட்டாரு
கனவேல் ரியல் மீ மியூட் பண்ணுங்க சார். Yes, sir.
Hello?
Please go.
Done, sir.
Please.
Done, sir.
So it will be more of a peritoneal involvement than the intestinal involvement in this patient.
In this, why do you think so? Why not a GI tract tuberculosis? Because it is a distension and pain abdomen.
Pain abdomen.
Yes,
These
sir.
two
But
you should be able to describe if you are thinking in terms of tuberculosis.
yes, sir. The distension can be because of ascites, which is seen more in the peritoneal type than the intestinal type. And
Okay.
if the patient has an intestinal type of tuberculosis, patient will have on and off subacute intestinal obstruction, and she will give history of vomiting in between if there was a stricture because of the intestinal TB.
Okay. Practically, which is more common disease if you are thinking in terms of tuberculosis? Is it a peritoneal type or a GI tract type? And in which age group, which sex?
Peritoneal TB is more common than the intestinal TB, sir.
Okay. In which age group, elderly or young age group?
Peritoneal is common in the common in the elderly age group. It is because of reactivation of the primary focus, which can occur later.
I don't know. Somebody asked, no, in the beginning, at this age group, is it wise to think tuberculosis as a first possibility? Tuberculosis involvement of the abdomen is more common in a younger age group. Younger age group, in both the forms.
Yes.
As you rightly said, the peritoneal is a more common variety than a GI tract variety.
Yes.
Okay, and the GI tract, most often they present as acute presentation.
Yes, sir.
Like you said, intestinal obstruction, and many times we diagnose as intestinal obstruction secondary to strictures.
Yes.
So if it is a chronic variety, it is a peritoneal type and occurs in a younger age group.
Okay.
Occurs in a younger age group. And I don't know, Srinivasan sir, others also, if she gives the history of like on history, the primary disease, probably it could be a malignancy because patient is female, ovarian malignancy as a first possibility. I think all of us should accept on
Yes, sir.
history, on history,
Yes.
on history
Yes, sir.
as a first diagnosis.
At this age.
Sir, at this age, for lady, we can think of ovarian
Exactly.
pathologist.
On history, on history.
On history, sir.
Yes,
on
sir.
history.
Agree.
And pain.
You can continue, ma. You can
Dr.
continue.
Ajit, sir, you are asking something. Sorry.
Yeah.
Yes,
And
sir.
what
If you-
her complaint of the pain is from the lower abdomen, what is described, that more favors the diagnosis in favor of malignancy, ovarian. That's what I want to say. Second thing, in your pain history, you have told
Yes.
it is intermittent and dilate. So these are the two words having a different meaning. So what you want to intend of pain of which organ origin or system origin in this patient?
In this patient, because the pain
Yeah,
is intermittent, it can be because of the hollow viscous involvement, sir.
Okay.
Intestinal.
See, your history says it is intermittent, dull aching type. So these are intermittent pains are usually occurs in which kind of the pathologies?
Intermittent will occur when patient has colicky pain affecting either any hollow viscous structures rather than a solid organ, sir.
And dull ache occurs in?
Dull aching occurs when the disease affects a solid organ. It is continuous when the patient, if in this patient, if the peritoneum is involved, patient will have a dull aching kind of pain.
So both are contradictory. That's what I want to clarify.
Yes.
How will you explain that thing? You yourself has contradicted yourself.
Yes.
what sir is trying to tell is that in the examination, slightly reduce the controversies. That is a basic thing, very
Yes.
important.
And second thing is peritoneal stretching. You are usually going to give rise a intermittent kind of a dull. Pain occurs at release, again the peritoneum stretch, again the pain occurs. So you can justify in that context, the patient may have some peritoneal pathology that is leading to the pain. It subsides, again it appears. So that may be the explanation. Otherwise, these are the two contrary words. So you should avoid that kind of a controversy.
Yes.
Or
if you
whenever
think
it is
of it,
there, try to think of justification.
Yes.
if you think of abdominal tuberculosis, how do you explain the only lower abdominal complaints are predominant in your case?
So lower abdomen pain because if it is affecting, if it is a type of intestinal tuberculosis and it is affecting the small bowel, patient can have a lower abdomen pain.
Why she didn't have any upper abdominal complaint, or on examination abdomen is also appears to be normal on inspection?
Yes.
What is your distension history? You can show the slides for a distension for how it has appeared.
It has started only since 1 month, sir, which was insidious in onset and gradually progressive. And
So it is a generalized abdominal distension.
yes, sir, it was a generalized abdominal distension, not localized to one region.
Okay.
In what form of abdominal tuberculosis there could be only a localized, generalized form of involvement?
Sir, in loculated type of involvement.
Okay. Insisted. We call it as insisted variety. It can be confined to the only one quadrant of the abdomen, whether the lower, upper, or predominantly lower abdomen. In this case, if you would like to still put it as abdominal tuberculosis confined to the only lower abdomen, you can always keep possibility of an insisted variety of abdominal cocks. They have also dull aching pain because of the stretching of the peritoneum.
Yes.
Yeah. Go ahead.
Okay.
Yes.
On inspection. Go ahead.
On inspection, there was fullness noted in the lower abdomen and both the flank region. All corresponding quadrants were moving well with respiration. The umbilicus is central and inverted.
I like to ask, why don't you use word distension and fullness in this patient?
Sir?
Why don't you use the word distension of abdomen rather than fullness?
So because the upper part of the abdomen does not look distended, the fullness is noted in the bilateral flank region and in the lower part.
We do have generalized distension word, right?
Yes, sir.
So why can't we use, do you mean to say that if it is whole abdomen distended, then and then you use this distension? I think obviously this is abdominal distension. Agree, sir?
Very perfect, sir. On inspection, you can straight away tell that lower abdomen is distended, and
Yes,
in
sir.
specific whichever quadrants or whichever region.
Particularly when flanks are also bulged up, right? Otherwise, fullness means to gastric distension or renal angle fossa, if you see there bulge, right? Or vague pancreatic.
Localized to fullness. Right? Yes.
Yes, okay. Carry on. It's okay. Just a word of advice.
Yes, sir.
Yes. Do you have a lateral view of a photo of this patient? You have put only both.
Yes,
okay, fine. Yes, that is very important in this case.
Yes, sir. So there is distension noted in the lower abdomen and also bilateral flank fullness noted. The umbilicus is central in position and inverted. Tubectomy scar is seen in the lower midline region. There are no visible peristalsis, no visible pulsations, no dilated veins, no sinuses, and the hernial orifices are normal. And the left and the supraclavicular fossa also there is no fullness. On palpation,
Just hold on. Anyone wants to ask questions related to inspection, sir, please.
Yes, your movement on respiration, have you observed it tangentially and from side?
Yes, sir. I have observed at the tangential position at the level of the abdomen, and all the quadrants were moving well with respiration. So there was no restricted movement in any quadrant.
Okay. Have you done leg raising test in this patient? Is it necessary?
No, sir, because of visible, there's no visible mass. So, leg raising test, I can't make out anything. We won't be able to make out anything.
So in this case, the distance is more predominant in the lower abdomen as compared to the upper abdomen.
Yes, sir.
Then if you are not noticing anything movement with respiration, then one should always do the leg raising test in such cases. Am I right, sir? Shanai, sir?
Yes, sir.
Even if you don't see anything, by raising the leg, if you find a lesser, means you know it is intra-abdominal, whatever that fullness. I have one question to you for the benefit of all pages. Just show that abdomen again.
Yes.
I just want to ask you, this is her normal abdomen. What is the difference between a fatty abdomen and distension? I want to ask this question because
Yes,
it's
very
important.
good. Yes, sir.
What is the difference? How do you know that this is a distended? So many patients have got this kind of a belly.
Yes,
Very
sir.
common.
Indian women with multiparous women will have most of the time with this abdomen.
What is
What
the
are
difference?
the hints?
What is the difference between obesity versus distension?
Sir, if it is obesity, we can see striae over the lower abdomen.
No. Yeah, the women will have a
In the
striae.
post parity, it may be there in the striae in these patients also.
Okay, just to not to waste the time, very simple. Distension is what patient complains of. Okay, obese patient will not say that I have got distension. It is his normal obesity. Is it clear? This is a very important, simple thing. Okay, very many times a little bit of upper abdominal distension patient comes and tell you in a pancreatitis. Abdomen is not like this. It is maybe flat, but still he says I am distended. That is what he complains of.
Yes. And on standing posture, there can be hanging skin if it is really obese.
Correct. Yes. Okay, please go ahead. Yes.
Second thing is you have
Sir.
to compare the general body fat with the localized abdominal fat. So if it is generalized body fat is more, then you can clearly go with the obesity. If it is not there and you're only localized abdominal distension, that goes more favor of the abdominal pathologies related to that.
And here patient has, I think, weight loss history, right?
Yes, sir. She has given history of weight loss.
These are all circumstantial hints.
Yes, sir. Yes.
Okay. How can you say that it is a distended abdomen? So what are the types of abdominal examination in relation to the counter of the abdomen? What are the types of abdominal counter is there? This is one is distended, others are?
One is scaphoid abdomen, sir.
Yeah.
And normal.
And other?
Scaphoid abdomen and
Scaphoid and distended, that's two only.
yes.
So either one should have a scaphoid abdomen or one should have a distended abdomen. So another is normal or flat abdomen, what we call it.
Yes.
Where if you can able to draw a imaginary line from the xiphisternum to the pubic symphysis, usually if the abdomen lies around that plane, that is flat abdomen. It is grossly up or grossly down below that, that is a scaphoid or a distended abdomen.
Okay.
Okay, go ahead.
Why did you keep the supraclavicular fossa in your inspection examination of the
On palpation, a mass of 10 into 8 centimeters occupying the
Rasagna, Dr. Khanna sir is asking you something.
I'm
Please
sorry,
read
sir,
it.
I couldn't hear.
No, I was asking that in the inspection of the abdomen, why did you keep the supraclavicular fossa no fullness?
Sir, if because she is an elderly lady, 65-year-old female with a lower abdomen distension, lower abdomen pain and distension. If in a case of ovarian malignancy, we can, if any case of malignancy, we can, we have to see for supraclavicular node involvement.
So should it be done at this time on inspection of the abdomen? Actually, Dr. Shenoy again and again tells about that, that it has to be at the separate time, you know.
You need to examine it separately.
Yes, it has to be. And you know, if you keep the possibility of supraclavicular fossa, but your first diagnosis is the Cox abdomen.
Yes.
So that also doesn't go together there.
Yes.
Okay, go ahead.
A mass of 10 into 8 centimeters, predominantly occupying the hypogastric and the umbilical region, extending 2 centimeters above the umbilicus till 2 centimeters above the pubic symphysis, laterally extending 4 centimeters on either side of the midline is palpable, and there is tenderness over the mass. The mass was firm in consistency with a smooth surface, ill-defined margins, and the lower border was palpable. The mass had restricted mobility. There was no hepatomegaly or splenomegaly, and the hernial orifices were normal. There was no cough impulse.
Okay.
Percussion.
Put a slide of the palpatory finding. Yes. So most of your swelling, where you will interpret what kind of this mass is. What is your interpretation of your mass?
So because
from a palpation,
yes,
what is the origin of the mass?
sir, it is predominantly occupying the hypogastric and the umbilical region, and the lower border is palpable. So from my palpation, I have ruled out an ovarian mass or a pelvic or a mass arising from the pelvis. And because it is in the central predominantly, it can be a mass arising from the small intestine.
Small intestine.
Really, can you really rule out the ovarian by saying that the lower margin is palpable?
No, sir. Most of the masses arising from the ovary, lower border will not be palpable, but some can become very big and occupy the central part.
And
Can be
particularly when still you have not arrived at per rectal, per vaginal examination.
Examination. Yes.
Right.
Okay. Go ahead with the other findings.
Percussion and all.
Then
Yes,
we'll
percussion. Yeah.
Percussion over the mass was resonant, and the flanks were dull on percussion, but there was no shifting dullness. And the liver span was 12 centimeters in size. And on auscultation, the bowel sounds were normal. Per vaginal examination was normal, and per rectal examination was also normal. On systemic examination, respiratory system, there were decreased breath sounds over left lower zone predominantly, but other systems such as the central nervous system, cardiovascular system were normal. There were no deficits noted. Because this mass is predominantly occupying the hypogastric and the umbilical region, and the percussion over the mass was resonant in nature, and the lower border was not palpable, I would like to give a diagnosis of abdominal tuberculosis predominantly affecting the small bowels. And I think that mass is a clump that matted bowel loops in the center.
Didn't have any obstructive symptoms, no?
Matted
so if you
bowel
think of intestinal tuberculosis which are matted together, how can be she free from vomiting and severe colicky pain?
These might have just been the adhesions making the bowel loops occupying the center, sir, but
What is the duration in your case?
6 months, sir.
6 months.
Any other site or any other form of tuberculosis when you are thinking of tuberculosis only? Let me put it that way.
Yes.
Other than bowel pathology.
We have to look for genitourinary tuberculosis in female.
No. This patient.
No, this patient.
There is no ascites.
Yes,
As per your statement, there is no ascites. You have
Yes.
tested only one exam test, only shifting dullness. Anything else except bowel involvement, still it can be tuberculosis if you are sticking to tuberculosis.
Sir, on respiratory examination, she had.
No. This patient.
No.
This lump.
Sir is asking for an abdominal examination
Yes.
also.
There is bowel
Simply.
and there is no bowel. There is no ascites. What else it can be?
In case of a tuberculous
Still
abdomen, you
abdominal
usually do
tuberculosis.
not get,
Yes.
if it is a suspected abdominal tuberculosis or a bowel tuberculosis, we usually do not get a mass like this,
Yes.
in a central mass like this.
Yes.
So what has leads to the central mass, which you can able to clinically palpable. Otherwise, in case of a tuberculosis, there is a generalized distension. Either it is a bowel distension or a fluid distension.
And patient will have colic, vomiting, abdominal distension may come and go.
I'm giving you the absolute hint.
Yes, yes.
Involvement of mesenteric lymph nodes can cause a mass.
Then how will you explain the resonant knot?
Because bowel loops are overlying the mesenteric lymph nodes.
Can you put the organ bowel along with some other structures of the abdominal cavity? It can put the central abdominal mass. That's what sir is asking. Have you heard about the caked up momentum?
Yes, sir. The momentum in tuberculosis can be studied with tubercles and they will be rolled onto itself, forming a mass.
What is cocoon abdomen?
Cocoon abdomen is when all the small bowel loops are plastered together and the momentum forms a cover over the small bowel loops and forms a.
Could it be this case?
That
can be
possibly this patient?
Yes, it can. It is possible if it is affecting the momentum and the small bowel loops.
Rasagna,
usually,
I want to have a clarification about your own clinical findings, if Shanae sir permits.
Yes.
You said the mass, the percussion over the mass is resonant.
Yes, sir.
And the flanks are dull.
Yes, sir.
And they are not shifting.
Yes, sir.
And the size of the mass is more than 10 centimeters.
Yes, sir.
Means occupying whole of the abdomen. Almost. Umbilical, hypogastric and flank.
Yes.
If the mass is the resonance, like resonance over the mass,
yes,
and a percussion note in the flank is dull, which is not shifting, indicating there is no fluid. So do these findings go mutually?
So it can be there can be ascites on the periphery, sir, because there is the mass occupying the center abdomen. There's no shifting dullness. If it is a loculated type of ascites or ancestral form.
Does your mass
do you think this mass is extending to the flanks or it is not extending to the
No,
flank?
sir, it is not extending onto the flank. It is just 4 centimeters on either side of the midline.
Then what is the cause for dullness in the flanks?
So fluid ascites, sir.
Then why it is not shifting?
Because there's a mass occupying the center of the.
You said it is mass is.
It can travel from anywhere.
If it is a
mass is not going to block the road of a fluid.
Exactly.
If it is a loculated type or ancestor type.
See, ultimately clinical examination is we are going to have our diagnosis depending on our clinical examination findings.
Yes, sir.
Okay. So
Yes.
just discussing everything on tuberculosis, what are the types, what happens, probably, yeah, may not, because we have not diagnosed only with the clinical examination findings. So how do you substantiate your dullness in the flank? And the mass is palpable only in the center of the abdomen. You're able to understand the question?
Yes,
sir.
Sir is saying your findings are contrary what you are putting as a diagnosis.
Exactly.
Otherwise,
is,
could it be still possible? Otherwise, could it be still possible?
So the mass in the center, I think it is the small bowel loops, which are matted together. But I can't explain.
You have examined the patient or a mass in changing the posture to the lateral side, and you have seen that it is a shifting or non-shifting, fixed mass or a shifting mass.
I think she said restricted mobility.
Yes, sir. Yes, it was not mobile. It had restricted mobility.
So in that case, it's very difficult to put. If it is not fixed, shifting anywhere, the bowel pathology to a localized one also becomes a little bit more difficult to explain. Okay, how will you proceed further?
So I just want to add that when this patient comes to the, obviously with the 6 months history of on and off fever and weight loss, no doubt in India, we definitely consider tuberculosis first. There's no doubt, even though 65 first. Second thing is, in fact, many of the people, as soon as I put my hand, 1 or 2 people said it is ascites. Actually, it was so nicely matted loops, after very nicely. a lower abdomen
Yes,
especially. Very often I have felt more in the upper abdomen rather than the lower abdomen like this. This is the first time I'm feeling a lot of things. And actually the flank eliciting that shifting dullness was difficult in this patient. To be honest with you. So there was,
yes.
I myself was not convinced about that shifting dullness part. Even though I felt there is some fluid there. I felt definitely fluid is there, but it was difficult to elicit. So this is how the clinical
Yes.
findings in
But
this.
but in abdominal tuberculosis there can be still possible, sir, because compartmentalized abdomen does occur in abdominal tuberculosis.
Yes,
So there could be flanks can
There
be
is a
still
location of
dull. It is a free peritoneal
location of
cavity.
the
The fluid
collection
can still
might be there.
Yes, sir. This can still possible. That's why I asked. It can still possible. Resonance in the center abdomen. Flanks can be dull. They need not be shifting dullness again. If you can explain the abdominal tuberculosis.
So just for the
And in this particular
benefit of all postgraduates, I want to ask one question. Sometimes there can be a very large ovarian cyst, very large. I have seen almost people have confused for ascites because tense, very tense. What is Ruler's test? Sometimes they may ask you this question. It's just for a clinical interest. That's all. Differences between large ovarian cyst and tense ascites. If you keep a ruler classical, if it is a large ovarian cyst, it can have a transmitted pulsations. Whereas in a tense ascites, you will not find, right? So this is how the diagnose. So I actually wanted PGs to understand loculated ascites as one possibility because of the fever and the mass. Suppose if the fever is not there, probably they would have also considered a retroperitoneal pathology. Also remember, I have seen very large gist of the sigmoid colon coming in the center there in the hypogastrium, large hypogastrium. So I just want all of you to understand
I have recently operated recurrent descending colon gist 2 months back. It is quite possible.
So hypogastrium. So common questions will be like why not urinary bladder? Remember, your urinary bladder, lower body is easily felt here. So that's how you rule out. So uterine pathology, large uterine fibroids, large. You can have a very huge fibroids. So all these things you need to keep it in mind. But this is a case of a different situation of tense cystic mass feeling like a firm swelling. Sir,
I think Rasagna, for presentation, you should not have thought of the diagnosis which you have come across. You should have gone per se de novo with examination findings, and you may have given a wide range of diagnoses. And I'm not sure about the probable diagnosis. I like to see it confirmed by the radiological investigations. This is what probably would have been little better.
What Dr. Shenoy said about the tense ascites and the big ovarian tumor, another test is that the flank will be dull in tense ascites, while the flank will be resonant in the case of the big ovarian tumor.
Yes, sir.
Yes, that's true.
So the balls are displaced laterally because of the tense large ovarian cyst. The flanks can be resonant.
And when you are talking about the Cox abdomen here, then I think we needed the more examination finding the chest. You said that there are decreased breath sounds are there, but we want to know, does the patient have a pleural effusion or not? Does the patient have consolidation or not? All those findings should have come in this. Can you give more findings on the chest?
Chest only, she didn't have no additional sounds, sir. Only decreased breath sounds in the left lower zone. Probably.
So how will you confirm that why there are decreased breath sounds?
I would like to do an X-ray, sir, to look for any pleural effusion.
Clinical tests.
Will you do any clinical examination for that?
Percussion.
You require to do the percussion, you require to look for the vocal resonance there, vocal parameters there. These things have to be seen to rule out does the patient have the pleural effusion or not.
Yes.
You do palpation by putting your hands like this. Look at the
we look for the
movement of your
respiratory. Yes.
What is Meeks syndrome?
Meeks syndrome is when there is an ovarian mass along with the ascites and the left side.
Okay. Shall we go ahead with the investigation, sir? It's already started.
Yes, sir. You can go for
How will you
investigation.
investigate this patient now?
So first, I would like to do blood investigations, including a complete blood picture where we look at the total leukocyte count, and then we have to do a ESR test in tuberculosis. ESR will be raised, and then we get a chest X-ray to see any consolidatory changes or cavity or any pleural effusion. And then we get an ultrasound of the abdomen, sir, to look for presence of ascites and involvement of any mesenteric lymph nodes or retroperitoneal lymph nodes. And I would like to do an ascitic tap in this patient to rule out tubercular pathology.
Provided there is ascites. This is what you have to say now.
Yes, sir. Yes, on
Yes.
ultrasound.
If it is ultrasonography.
Yes.
How will you confirm tuberculosis on ultrasound?
Sir, on ultrasound, we have to look if there is ascites, and if it is ascites, to look for any loculator or encysted ascites. And we can look for involvement of the mesenteric lymph nodes, and we can see for any bowel wall thickening, and omental thickening also sometimes can be made on ultrasound.
Yes.
Now, in this patient, what is the first thing you want to see on ultrasound?
So to look for the presence of ascites, and
No, ascites can be in the malignancy also, ascites can be in the tuberculosis also. So
Yes.
what is the first thing you want to see here?
What is all discussion about? Priority of your probable diagnosis.
the small bowel.
Would you like to check the pelvic organs? No. Would you like to check the pelvic organs in this case?
Yes, sir.
On
Let me
ultrasound?
see what is
For
this
the
lump,
pelvic pathology.
from where it is arising.
Yes, sir.
Yes, the origin of the lump is the first thing to know. What
Yes.
sir is asking you.
Yes, sir.
And along with ultrasound, you should have said transvaginal ultrasound also.
Yes, sir. To rule out.
That will be showing you the uterus, though it is atrophied, particularly if there is free fluid around.
Yes,
And
sir.
ovary small, if they are visible or not. This is what our intention is to, so that we can focus our mind to the other diagnosis.
Yes, sir. Yes.
What was the
How on
ultrasound?
the ascitic tap you confirm it is tubercular?
Yes, sir. Sorry,
How do you confirm on ascitic tap that this is tubercular?
So first, on doing the ascitic tap, the fluid will have a serous or a straw-colored appearance, and then on analysis, it will have a elevated total protein, and the serum ascitic albumin gradient will be less than 1.1. And also the presence of adenosine deaminase also will confirm the diagnosis of tuberculosis. And also ascitic fluid LDH will be elevated in the, if it is a tubercular pathology.
How much is the ADS normal?
It should be less than 10.
No, 35. You know?
35.
Approximately 35 international units.
Yes.
Then what next you will do after the ultrasound?
If the diagnosis of, and on the ultrasound, if there is the ovarian pathology is ruled out, and the origin of the lump is diagnosed as arising from the small bowel, that means the small bowel loops are seen and the ascites is seen, we do an ascitic fluid tap, and if the tubercular pathology is confirmed at that, I would like to start anti-tubercular treatment for this patient, because she doesn't have any other acute presentation as to which the patient will not require surgery at this time.
You don't want to do the X-ray of the chest of this patient?
Yes, sir. Chest X-ray also to look for any pleural effusion or cavity or consolidation of the lung.
So intestinal tuberculosis is a primary tuberculosis or secondary tuberculosis?
Intestinal tuberculosis is a primary tuberculosis, sir, whereas peritoneal can be a secondary.
What do you understand by primary tuberculosis and what do you understand by secondary tuberculosis?
Secondary is from spread of the pulmonary TB through either ingestion of the bacilli or through a hematogenous spread or a lymphatic spread. Whereas primary is that organ is itself primarily affected because of ingestion of any Mycobacterium bovium, as in intestinal TB.
So in primary tuberculosis, what is the common site in the intestine?
If the patient is having it,
Terminal ileum is more commonly affected, so, and the ileocecum.
Which part of the terminal ileum? Or is it the terminal ileum itself or something else?
The ileocecal junction is more commonly involved.
Now,
what are
what
the
structure
types
is
of-
exactly involved in that?
So the Peyer's patches are involved.
The Peyer's patches and the lymph nodes at the ileocecal junction. Okay?
Yes.
That makes the primary tuberculosis here.
Yes.
And secondary comes from the lungs.
Yes.
And the secondary tuberculosis are more virulent in immunocompromised patients.
Immunocompromised people.
Okay.
You said the diagnosis can be established by aspiration, by SAG and all. Is it a confirmatory evidence?
No, sir, it is not confirmatory. For confirmatory, we can go ahead with, we have to do gene expert or we have to have a tissue diagnosis.
So what I'm trying to tell is if there is no sputum or chest is normal, no sputum AFB, we can't demonstrate that.
Yes.
All these are indirect. Let us say there are no lymph nodes at all palpable in the body. All these are indirect methods, including SAG and all that, whatever you mentioned up to now.
Yes,
What, sir, we have done CT scan in this patient. Do you have the images of that?
Yes, sir. One second.
Can you show that, sir? Yes. Yeah.
So this CECT abdomen of this patient, sir, which is showing fluid predominantly in the flank region around the small bowel loops.
So this patient has not only had encysted, sir, he also had ascites in the flank. That's what the question which was asked by Dr. Gurshantappa to you earlier.
Yes.
Even though we are not very fairly convinced about the diagnosis. See, the question asked you was ultrasound. They also mentioned thickening of the bowel wall, in fact.
Yes.
So thickening of the bowel wall, matted loops, in fact, fluid sequestration, etc., etc.
The gross mesenteric nodes are there, sir.
Yes.
Yes.
Can you show? Just
there
go
is a
back
dilatation
one.
of the loops are also visible.
Yeah. If you see carefully the mesentery.
Dilatation.
Yes.
Yeah.
In fact,
There is enhancement.
Enhancement, and actually in a Crohn's disease, it will be much more, this mesenteric specially standing. It's in fact like a comb, comb appearance. It's also seen here, but not that great like that. Yes.
And here, I think bowel is also dilated.
Yes,
with
I had edema.
Intra-bowel fluid within the bowel also.
Yes.
Yeah, and there is, I think, one cystic collection in the left upper abdomen. Whether it is a stomach or, yes, this is a dilated stomach.
So that's a stomach.
That's what I want to convey.
Stomach.
Even there is a fluid in the upper abdomen also, sir.
Yes,
Some
sir.
hepatic portion. The Morrison's portion.
Yeah. So
Yeah.
again, this when ultrasound CT is asked, please remember also to rule out a visceral tuberculosis. You understand, no? I'm
Yes.
not telling that it doesn't happen, because these are all the points to see the liver, to the spleen, and of course, mesenteric nodes are more commonly involved rather than parietic nodes. If parietic are dominant, means it will go for probably a different, probably a lymphoma or something. Not that it cannot happen. So mesenteric nodes, mesenteric standing, stricture, dilatations, cocooning effect, ascites, loculations, granular momentum, more common, of course, in children. So these are the things, various things you need to look and mention in the exam.
Yes.
I think in this patient examination, there may be a doughy feel of the abdomen. That's what I feel. Localizes of the collection, localized swelling, but rest of the abdomen may have a doughy feel.
Sir, any other questions to her, sir, related to the investigation? And what probably the next is to final confirmation, sir. We did a diagnostic laparoscopy. Please go ahead. Please go ahead with this.
So this is the chest X-ray of the patient, which is showing left-sided pleural effusion minimum. And we have done an ascitic tap, and the fluid was straw-colored appearance, and the adenosine deaminase was also elevated. And the fluid cytology didn't show any granuloma or any atypical cells, and the sputum and the for AFB and gene expert were negative. And we have done a colonoscopy. There were multiple colonic diverticuli, but there were no
symptomatic.
Yes. And because there were no any palpable lymphadenopathy, nothing, we have done a diagnostic laparoscopy for this patient, and we have seen that there were multiple tubercles over the peritoneum. The peritoneum was fully studded with
as it has been already pointed out, lower abdomen, the bowel was distended, lower abdomen in fact. So we're able to get in from the upper abdomen, and bowel loops were not easily separable at all. But luckily we could get those tubercles on that surface.
What precautions you thought when you were planning to do diagnostic laparoscopy when you are suspecting abdominal tuberculosis,
yes,
particularly?
Very important.
How it differs from other abdominal when you're planning for a laparoscopy, diagnostic laparoscopy?
Sir,
what precautions, what caution you have to be exercised in such cases?
We have to be careful while inserting the ports because the whole bowel loops will be clumped together and plastered in the center of the abdomen.
Yes.
So
Access into the peritoneal cavity is the most difficult in such cases. Preferably go for palmar point if you're thinking predominantly in the lower abdomen, or you have to do the open access. In such cases, you have to go for the open access and then enter into the peritoneal cavity, then introduce the scope. Because when you are clinically thought of abdominal tuberculosis, diagnostic laparoscopy itself can be a dangerous procedure.
Yes.
I think open will be best.
Yes, open technique.
Yes, sir. Open techniques.
Open technique of trocar incision would be best. Otherwise, also, if you are habituated, that gives the best confidence.
Yeah.
Go at the palmar point. So in this case, it is predominantly lower abdomen. Probably you may get better access in the palmar point.
Rasagna.
Yes, sir.
After doing the scopy, anything more important when you do scopy for such patients?
Diagnostic laparoscopy, sir.
Yeah, after doing this, anything more important than doing scopy? After doing scopy?
So we have to be careful in evacuating the pneumoperitoneum so that we don't.
Okay. Anything else?
Patient is shifted. Now what?
Anything else? You have done everything nicely.
Patient is fine.
And you have gone out. As a surgeon, you left the OT. Anything else?
Patient is very fine. But still, sir is worried about something else.
And more so in this case.
Yes.
So we have to fumigate the operation theatre.
Oh,
not only operation theatre.
What immediate post-op? What post-operative complications is evident in such cases?
Which is more important than the known entity and everything? Every surgeon is worried about that. May not be about this patient. May not be for this patient.
Autoclavable instruments and fumigation of the laparoscope. I mean, sterilization is very important.
Yes.
Gurushathapa sir, you wanted that answer?
Yes, sir. Yes, sir. Which probably many of us may not give much importance.
Yes.
It is if you don't take care of sterilization of your used instruments, you are going to induce tuberculosis for the next operating patient.
Yes.
Very important.
And so many patients.
Yeah.
Yes, sir.
These are some technical thing. Other thing, I think what probably were expecting was a fistula. So that one has to be careful. So before you close the peritoneum, look into the bowel surface again and again carefully.
Yes.
One more is a delayed is a port side sinus, sir. Port side sinus is very common when you abdominal tuberculosis, when you plan for a diagnostic laparoscopy.
My side, 1 or 2 questions. What is a differential diagnosis for such so-called nodules, whatever you are shown in this picture? differential diagnosis?
So it can be peritoneal carcinomatosis in an advanced ovarian malignancy or a carcinoma stomach.
No, don't jump into
In this patient,
carcinomas.
it will be from an ovarian malignancy.
No, peritoneal carcinomatosis is okay, not necessarily ovary. It can be due to any other cause also, not necessarily only ovary.
Yes.
Pseudomyxoma, you also need to know the pseudomyxoma, and just for a completion, pancreatitis with the fatty necrosis. Okay, so you need to know, have a 1 or 2, 3 list of differential diagnosis when you find such kind of lesions in some of the, and in 1 or 2 situations I have seen subacute peritonitis patient would have had much before. Somebody has put the scope, suspected tuberculosis, it has come as no evidence of tuberculosis. It is also possible. We don't know why it happens, but it is possible. These are the
Dr. Asagna, will you put a drain in this patient?
No, sir, because patient will that ascitic fluid will keep on accumulating and draining.
No. What are the complications of long-term
that is not
complications?
the only reason.
And the drain can also be adhered to the small bowel, and it can.
No,
there are already distended bowel loops which are not normal otherwise, right? So this can lead to fistula formation.
Fistula formation, yes.
And once you remove drain, there can be sinus.
Yes.
This photograph, so it is an angry look.
Active tuberculosis. Looks like active tuberculosis.
Yes.
Dr. Khanna sir, or anyone, any other question? Dr. Patel sir, or any Dr. Rajshekar, any questions to us?
Okay, TEL granuloma is another differential diagnosis. You know, if somebody has done the laparoscopy first and used the gloves which were there, which are full of the TEL. You know, in our days, we used to get out of the TEL granuloma.
Starch peritonitis.
So what was the biopsy report in this patient?
So it has shown
cases, total cases.
granulomatous peritonitis suggestive of tuberculosis. So multinucleated foreign body giant cells, lymphocytes, and plasma cells were seen.
Okay. So how did you treat this patient?
So the patient has been started on anti-tubercular treatment. So
what you have given?
So we have started with isoniazid, rifampicin, pyrazinamide, and ethambutol combination. So for 2 months first.
And
then we give a continuation phase for about 4 to 6 months.
Now, what are the various side effects of these drugs? What is the side effect of rifampicin?
Rifampicin, patient can have a orange colored urine. Or isoniazid, patient can have a burning sensation of the feet. That is why we give a vitamin pyridoxine supplementation along with it. And these are primarily also hepatotoxic drugs. So we have to monitor.
That is very important, that these drugs, rifampicin, the INH, so many times you have to carry out the liver function test beforehand.
Yes.
And then you have to monitor that.
Yes.
That what is happening.
You need to tell when this biopsy come, you need to tell that I will get the gene expert also today. It is mandatory. So know the rifampicin resistance. So you need to know that. So 4 drugs regime, that what you start with, and then you give 3 drugs. So remaining 4 months, and then you need to follow up these patients. And that's what is the usual treatment which is expected. And how do you follow up that she's responding to your treatment? How do you know she's responding? She comes after 1 month, let us say. Quickly, what are the things you look for?
So the
how do you know she's responding?
The symptoms also will improve, and the patient abdominal distension also will come down, the ascites and all.
What we expect you to say is that symptom correct. So fever, weight gain, that ESR, whatever you said. But other than that, ascites also may disappear. She can go for intestinal obstruction also. You need to remember that. Not that that everybody will be completely cured. There's a possibility of adhesions formation. That's all from my side, sir. Please.
Dr. Asana.
Any indication of steroid here?
No.
No.
When
What
do
are the
you use
indications
steroids
of
in
using the
tuberculosis?
steroid in tuberculosis?
I don't. Not sure.
You could probably, this is one of the case where you may require to have the given the steroid here. So if there's adhesive type of the peritonitis is there, here you could see that all the bowel loops were just stuck to each other here. So that is one indication. And then sometimes in the patient have the meningitis. So those are the few indications where you can use the steroid for these patients here.
Yes.
And probably that will prevent stricture and further need for surgery.
Sir, in our patient, of course, our hospital protocol, once the gene expert is done, it is referred to the pulmonary tuberculosis diseases department. Of course, in consultation with us, they have not started steroids. Just for the information I am telling. So
Generally, they avoid it because it masks some clinical signs and symptoms. So usually, it is not indicated unless what is said meningitis is suspected COX.
Yes,
so then there is a definite role. Abdominal tuberculosis generally we don't advise because with or without treatment, ultimately it's going to heal by fibrosis. So future complications like strictures and adhesions are bound to happen in abdominal tuberculosis.
So for the sake of completion, only last one, and whenever you have an encysted variety of a mass, something like this, say umbilical region or say lower, can you just tell 2-3 differential diagnoses other than this encysted? Maybe 30 years young patient, 25 year.
In the umbilical and hypogastric region.
Something like this. Yes.
Something.
Male, female, doesn't matter. One or two.
Younger females.
What are the possibilities?
First, we can think of a mesenteric cyst, sir.
So you need to keep it in mind. Mesenteric cyst also. Yes.
Okay.
Anything else? Any other possibilities? Think of a large cystic lesions. Ovarian we mentioned, encysted, mesenteric, even retroperitoneal, urogenital remnants, all that, they all can give rise to form a cystic masses, including duplication cysts, Dr. Kanakavellu has told.
I think the hydrated should always be kept in mind, This is also one of the entity that will present just like the Cox abdomen. It can present any type of the presentation may be there in the hydrated cyst of the abdomen.
Dr. Asana, how did you close the laparoscopic ports following the biopsy? I'm sure you would have faced challenges when you're doing a diagnostic laparoscopy in tuberculosis patient, especially in presence of ascites.
Yes.
Were you there for the diagnostic laparoscopy, doctor?
No.
Were you there?
Did you attend the surgery?
No,
Sir is
sir.
asking.
No.
Okay. So the point is, most of the time, these patients end up having persistent leak of ascites.
Yes.
Please alert this patient. It takes up till 6 weeks, 3 to 6 weeks of ATT for the ascites to stop.
Yes.
Few times in our department, we have ended up using a colostomy bag around the port because it becomes a real trouble for the patient because no amount of dressing change will help these patients.
Yes.
Unless the disease comes under control, this becomes a nuisance. So the lesson learned is very simple. Palmer's port, minimize the number of ports. As much as possible, place supraumbilical ports, non-dependent ports. That's
in fact, we put the supraumbilical only here. Yes, correct.
And then the other thing is, make sure there is some special vehicle needle called J needle. So this takes an advantage of not injuring anything underneath. You should be aware, Ethicon produces, few other companies also produces. I'm not sure about the number 2341 if it is the Ethicon reference number. So J needle helps us to go through all the layers, and the sharp end is, it's like you would have seen fish hook, no? Like for the something like that. It's a specialized.
Yes.
So that is an advantage. And then ensure you take at least, if you are using ports, ideally 5 mm telescope and 5 mm ports are optimal. Never exceed more than 10 millimeter ports. 12 millimeter, 11 millimeter. I am not. I do not know the answer, but anything plus of 10 millimeter, the incidence of ascites leak is more in tuberculosis. These are the few things as a, because now you young generation are more towards minimally invasive surgery, you should be aware of those things.
And if you have 5 mm port, use that for closing the 10 mm port under guidance.
Under guidance, yes.
Very
The
beautiful
ideal-
point. Very nice points have been highlighted. Thank you.
Ideal
Dr.
point is 5 mm port, 5 mm telescope, 5 mm instrument. So the risk of other things are lesser. And one more thing, I'm sure the oncology people will be guiding us also. What really, when you do an open port also, never once your port peritoneal access has been obtained, always put your little finger or index finger, gently stay around the parietal wall, right? You go around the parietal wall, ensure even after making an open port, passing a port is also risky at times.
Yes, sir.
Right? So not that open port is safe, but in tuberculosis conditions, many people even after making open port, the ports have entered into the loop. And more so in tuberculosis condition, it is unpardoning. Otherwise, you can repair the bowel. In these patients, especially if you have a cocoon or something, it becomes a real mess. That's what everybody is trying to advise you. Ensure you take time to have access. Safe access is the most important safety. All right.
Converting into laparotomy such is much more difficult, provided if you injure the bowel. It's not the easy job.
You end up having open abdomen many times, sir. It's not a very easy, benign condition, becoming patient very dependent on to the hospital for a longer time. So the other thing you should be aware is, what is the role of CA125 in this patient? Did you do that?
Yes, sir. It was marginally elevated, about borderline.
When do you think, or when do you consider CA125 is malignant, or do you have any rationale of using CA125 for malignancy?
No, sir. It can be elevated in some benign conditions also. It is not. It can be elevated in benign ovarian masses or any pancreatitis patients also. And
can that be used for treatment prognostication in tuberculosis?
In tuberculosis? No.
In malignancy, yes, no doubt about it. In ovarian malignancy, no doubt about it. Can that be used? It cannot be used because they do not have reliable rise or reliable drop. That is a message you should be very clear.
Yes.
Most of the time, it does not exceed 3 times the lab normal. But many incidences, when there is a very actively multiplying tuberculosis phase, people have reported even CA125 up till thousands. Right?
Yes.
So CA125 helps your diagnosis, but it is not very specific. That is a message you should be aware of.
Yes.
All right. Can gene expert be negative and biopsy be positive in condition? What is the percentage of those things?
Can be negative and biopsy positive, sir, but percentage I'm not sure.
Again, it varies from lab to lab. Gene expert can be negative. See, it is the most available specific test. I'm sorry, sensitive test, but it cannot be like, there cannot be true negatives. So histology is the only specific test, final test.
Yes.
And other thing, when you have, how do you handle situations when the pathologist tells it is non-caseating granulomas?
So we also ask for AFB staining of that specimen.
Okay. Apart from that, see, this is one other challenge, especially when the tuberculosis is actively multiplying, right? You may not have very typical caseating granulomas like a typical tuberculosis. So it is always better you do a peritoneal strip biopsy. Never do a punch biopsy or a short biopsies. You take, the guideline says you make minimum of 5x1, that is 5 square centimeters of peritoneal tissue should be handed over to the pathologist for a optimal biopsy.
Okay.
These are few things you should be knowing, because when you are practicing, you should not have a trouble with the pathologist telling, sir, your tissues are inadequate for reporting.
Yes.
You do a DLAP and the pathologist telling this will be always be a challenge. All right. And more so, never use diathermy for using peritoneal strip biopsy.
Yes.
You remove the strip of peritoneum, then you can use energy sources for hemostasis. Most of us end up using powered scissors or hard scissors to do a peritoneal thing. People end up having like they lose the viability of the peritoneum for the pathologist to report. These are small inputs you should be aware when you're doing a staging laparoscopy.
Yes,
And more so, what will be your challenge if you are not able to access the full peritoneal cavity? What will be the solution for that? Many times, laparoscopy gives the advantage because you have a bird's eye view of the entire peritoneal cavity. Tuberculosis is one condition where your visualization can be very much limited. You may end up in one cavity and visualizing only through that, where access to the other areas may be very challenging. How do you handle that? The very simple point is, what are the other non-conventional access locations on the to the peritoneal cavity?
So we can access.
Lateral abdominal is palmus, right? Ensure you insert a Riles tube before doing a palmus. That's the most important simple thing. You can do suprapubic, you can do paraumbilical, and more so now the current guidelines are coming up, still not formed as guidelines. You can use ultrasound guided first port insertion, especially in case of peritoneal carcinomatosis. These are the guidelines of HIPEC. So it looks it is very easily adaptable for us also. So ultrasound guided VRIS insertion or ultrasound guided first port insertion seems to be more safer. I'm sure all the theater has ultrasound gadget. This is little far fetching for a PG level, but as a practitioner, you're going to be into practice next year itself. The first port, when you're not able to hit after 10 minutes of trying, having safe peritoneal access, you have to resort to other safety measures.
Yes.
That will be the right approach. Faculty, are there any other questions? I think I took longer time. So how do you monitor this patient? You have started treatment. When do you want to repeat the scan?
Ultrasound scan, sir.
How do you follow this patient up? When do you want to see the patient again? When do you want to do the investigations again? So what is the sterilization time? That is bactericidal duration of ATT you need to give. Let me put a question very simply. What is the multiplication time of tuberculous bacilli? Don't worry. If you are doing good, questions can be like this, but you should go back to microbiology. That helps you to understand the disease well.
Yes.
All right. You did very well. Let the other faculty conclude. Then we move on to the next case.
Yes.
Dr. Rajan sir, Dr. MRS sir, do you have any questions or comments to add?
No, sir. Most of the part is already covered. So I think we should conclude this case here so that we can proceed to the second case.
Dr. Rasagna, do you have any questions to be clarified with the faculty?
No, sir. No, sir. I think everything is explained well.
Go back today, read about the Mycobacterium microbiology.
Yes,
That is definitely will be able to understand the disease better.
Yes, sir. Yes.
All right.
Yes, sir.
Kanna sir, Shanai sir, any other questions, sir?
Nothing.
Thank you. Thank you, Rasanna.
Thank you, sir.
Share your screen. Please stay back for the remaining case discussion.
Yes, sir. Thank you.
Now we have Dr. Monica. Again, it is from the Department of Surgery, KIMS Hubali. Ishwar sir, and under the headship of Dr. Guru Shadapa sir, this case has been contributed from Ishwar sir's unit. Dr. Monica, please introduce yourself and then start your presentation.
Yes. Good evening, everyone. Myself, Monica from KIMS Hubli, postgraduate third year. I'm going to present a case of mass per abdomen under the guidance of Dr. Ishwara Rosmani, Professor and Unit Chief, Department of General Surgery, KIMS Hubli, and HOD, Dr. Gushantappa Elgachin, Professor and Head, Department of General Surgery. Coming to the case scenario, here is a 34-year-old male patient who resides in Savdathi, Dharwad. He is a farmer by occupation. He presented with chief complaints of pain abdomen since 3 months, mass in the right upper abdomen since 2 months, and melena since 15 days. Coming to the history of presenting illness, the patient was apparently normal 3 months back. Then he developed complaint of pain abdomen since 3 months, which was insidious in onset, more in the right upper abdomen, which was dull in nature, continuous type. It was not related to food intake, and there was no it relieves on taking medication, and there was no radiation to back, and it was not associated with vomiting. And he also complains of mass in the right upper abdomen since 2 months, which he noticed, which the patient noticed with the onset of the pain, which was gradually progressive in size. There was also history of passing black colored stools, history of loss of appetite and undocumented weight loss. There was history of easy fatigability, history of early satiety. There was no history of nausea, vomiting. There was no history of jaundice. There was no history of dysphagia, no history of hematemesis or bleeding per rectum, no history of any alteration in the bowel habits. There was no history of hematuria, no history of cough, breathlessness. There was no history of hemoptysis. Coming to the past history, there were no similar episodes of pain abdomen in the past, and a patient doesn't give any history of previous surgeries, and there was no history of tuberculosis in the past. Associated history, patient is not a known case of hypertension or diabetes mellitus. Coming to the family history, patient doesn't give any significant history of deaths related to the colonic gastric in the family. Coming to the personal history, the patient consumes a mixed diet. His appetite is reduced because his appetite is reduced, and his sleep is disturbed due to the pain abdomen, and his bowel or bladder habits are normal except melena. Coming to the habits, he's a known tobacco chewer since 20 years and non-smoker and non-alcoholic. To summarize history, here is a 34-year-old male patient who presented with pain abdomen since 2 months, mass in the right upper abdomen since 2 months, melena since 15 days, and loss of appetite and undocumented weight loss and easy fatigability, who consume mixed diet and tobacco chewer. So my provisional history could be query carcinoma stomach or query HCC bars secondaries in the liver. So shall I continue with the general physical examination?
Wait. Other examiners to ask on the history basis. Shanay sir or Kanna sir, can you take please?
34-year-old male patient with the abdominal pain as a first complaint. How did you think of carcinoma stomach as a first possibility? Tell me.
So patient gives history of loss of appetite, early satiety, weight loss, and melena, sir.
You have told me first complaint is pain abdomen, 3 months duration, correct?
Yes, sir. Yes, sir.
Okay, I'll put it this way. What do you think the cause of the pain? The same fundamental basic question. Yes.
Yes, pain abdomen, it can be due to solid organ involvement or the hollow viscous organ involvement. Here the pain, more it is in the upper abdomen, sir. So to rule out the upper abdomen pathology of liver or stomach or transverse colon of the pancreas. So in the differential diagnosis, I couldn't get any radiation of pain to the back.
So what you would have probably told is it a dull aching continuous pain which patient has felt in the upper abdomen?
Upper abdomen, yes,
so
sir.
it is obviously not related to the stomach. It could be related to liver. We want you to remember that way rather than staying in the stomach. Stomach doesn't produce that kind of a dull aching pain or something. Either you can have a hunger pain related to the peptic ulcer, whatever pathology, or it could be some kind of a pyloric obstruction is there. Patient may feel some kind of discomfort, right? That is what we will. Yes. What is melena means?
History of it is a passage of altered colored blood stools due to the as a hematine, which is altered, alteration of the blood.
Why did you straight away narrow down to the stomach? Why not, suppose I say it's a right carcinoma cecum, suppose I say.
So, but the patient doesn't give history of any alteration of the bowel habits.
Transverse colon.
There is no history of alteration of the bowel habits, sir.
What do you mean by alteration of bowel habits?
It can be due to altered bowel habits. It is either can be constipation, alternating constipation and diarrhea.
Just don't be under the impression that every colon will have alternating constipation, diarrhea. It will never happen. Don't be under the impression like that.
Yes.
A carcinoma, the cecum, what is the presentation?
Usually it is.
Doesn't produce constipation at all. Never
Yes,
produce the constipation.
Yes. But in this case, even the patient gives history of early satiety. So in case of colonic cancers, the early loss of appetite will be there, but early satiety.
Is it possible that that could be a large mass compressing the stomach and patient can have early satiety?
But the patient doesn't have any obstructive symptoms of vomiting or dysphagia or any bowel rolling movements or jaundice, features of jaundice, anything.
Early satiety and dysphagia are two different things.
Yes, sir.
Except the dysphagia here.
Yes, sir.
Dysphagia usually related with the esophagus or
esophagus or esophageal junction.
Gastroesophageal junction
Yes.
side of the things, not
Yes.
the stomach one.
Stomach, yes, sir.
Whenever you have a 34-year-old young patient, I'm not trying to say it will not happen.
Yes.
Please remember that you need to also consider a liver pathology. That is fine.
Yes.
There could be a space occupying lesion in the liver, possible, not that because of the pain. But
yes.
You cannot straight away jump and say carcinoma of the stomach based on loss of appetite. You
Yes.
need to keep it in mind also other possibilities of
Yes.
any larger liver lesions, liver masses, a large, any liver mass for that matter. Hydrated cyst sometimes, not that it is in this patient. Because
Yes.
patient is a young patient, no? You're only 34-year-old patient.
Yes,
There's absolutely no otherwise, right? Undocumented weight loss means what? What do you mean by that?
So the patient is not aware of exactly the amount of weight loss, but he says due to his loosening of clothes and
Noticed by others.
noticed by the attenders.
So what do you mean by significant weight loss?
It is a loss of more than 10% of body weight in 6 months of duration.
Unintentional.
Unintentional, yes.
Yes.
Okay, you have said about the right upper abdominal with the CA stomach. So what is
Yes.
the normal anatomical landmarking of the stomach? Which part of the stomach lies in the right side of the abdomen?
It usually involves the pyloric part and the antrum parts. Pyloric region of the stomach.
Pyloric. So they are usually in the midline rather than truly in the right side.
Yes,
so
sir.
when you are saying that it's the right side of the lump, what Tinoy sir is saying is very much, since beginning he is insisting you should not focus on the CA stomach.
Yes,
When your
sir.
mass is on the right side. So
Yes, yes, sir.
where there is a right side mass, you more focus towards
Liver
biliary
pathology.
masses in the mind.
Yes, sir.
Until you go and examining the patient and you confirm something otherwise.
Yes,
so from
sir.
history, to put a CS stomach straightforwardly, it will be a little bit more difficult to digest by the other examiners also. That is the message by sir.
Yes, sir.
That's what I feel. Am I right, sir? Sir?
Yes, sir. Definitely.
Yeah.
Dr. Rajan, sir, you are with us? Yes, sir.
Yes.
Dr. Sahai also has joined, sir.
Welcome, sir. Good evening, sir.
Good evening.
Good evening. Good evening, sir. Good evening. Good evening.
Okay, go.
Okay, Monica, since you explained the melena and early satiety, they are the predominant symptoms of stomach pathology or predominant symptoms of liver pathology?
It goes more in favor of stomach pathology, sir.
Could it be still there in liver pathology?
Sir, in the case of liver pathology, early satiety doesn't give history, sir. And melena, it is unlikely in case of liver pathology.
What is the difference between iron tablets causing black color stools and melena? It's very commonly given tablet in the general hospitals or our house, wherever it is. Patient says, I pass dark stools, and you call it as melena?
No, sir. But in this patient, there is no history of any drug intake.
No. Any other specific history you will ask is foul odor is very classical, melena with the attack of, they usually have anemic and syncope. They may even feel like, that giddiness and all.
Yes.
So that doesn't happen in iron tablets. Okay, you need to know this.
Yes.
Because, and also, it's not the birthright of stomach alone that to say satiety and melena. You can have a portal hypertension patient with a hepatocellular carcinoma with a GI bleed. I'm just trying to open your mind. Open your mind. 34-year-old fellow, tobacco chewer, who says you may be alcoholic also, can have a large liver tumor there or liver varices. You may bleed from there. And early satiety, these are all very subjective ones, early satiety and all. So you need to really keep it in mind, 2-3 possibilities at this juncture and proceed, right? Okay. Yes.
And all your symptoms are more favored to the chronic liver disease itself, rather than exclusively to the stomach.
Yes.
So you just think logically to change the order of your thinking.
Yes.
That is the simple message.
Yes.
Okay. Second thing, if it is such a huge mass, why there is no stomach obstructive feature in this patient? If your diagnosis is first, we believe it is a CS stomach, right? So why patient is not having any obstructive feature with such a huge mass?
So the tumor may be in the body of the stomach. This mass may be presenting with the hepatomegaly, sir. When there is it is in the body of the stomach, the usually obstructive symptoms presentation will be very late, sir.
Okay, so you want to say that this is associated with the stomach with the secondaries in the liver?
Yes, sir.
Okay, fine. Go ahead for your examination.
Yes.
Any sir want to ask any questions?
What is the other drug which can cause the black color stool? Apart from the iron which is there, which was used in the olden time for the peptic ulcer.
Sucralfate, sir.
Not sucralfate.
Bismuth, sir.
Bismuth is one.
Yes, sir.
Now, you said there's a mass in the right upper abdomen is there.
Yes, sir.
Now, mass in the right upper abdomen, and if you think it's the malignancy, then the commonest, at least in our setup, will be the carcinoma gallbladder.
Yeah. Okay, sir. Yes, sir.
Okay. We will not give the hepatocellular carcinoma at the age of 34 years.
34 years.
Yeah,
Yes,
we will not give that too. But the carcinoma, the gallbladder, it can be there in the 4th decade.
Yes.
So that will be one of the differential diagnoses we really want to keep that.
Yeah. Yes, sir.
Short duration of symptoms, could it be favorable to you in this case? Because he has got hardly 3 months of duration, though it is a young patient.
Sir, I did not get it.
No, he has got very short duration of symptoms. No, only 3
Yes,
months.
Sir.
All this patient developed mass, pain
Yes,
abdomen, and satiety, all these things.
Yes,
The younger patient. So,
Yes,
what sort of malignancy you're suspecting? Predominantly influenced by his habits, because he's a known tobacco chewer and alcoholic and other things are there. Then you also inquired about the family history of other malignancy. What
Yes,
you are
sir.
trying to exactly correlate in these such histories?
Sir, early age of onset, it can be in with syndromic manifestations where there will be early manifestations of the carcinomas.
You mean to say familial?
Yes, sir, familial syndromic.
Okay. You also asked about the history of previous attacks of pain abdomen in the past. What is the importance of asking in such cases when you made the diagnosis of these two possibilities?
Sir, if he is having any history of repeated episodes of pain abdomen due to any peptic ulcer diseases, I wanted to rule out the cause for this etiology, sir.
will they prone for carcinoma? The peptic ulcer symptoms.
And chronic.
Can they produce carcinoma stomach if such symptoms are there in the past?
It is likely, sir, but in order to rule out, I wanted to ask.
Okay. Sir, please take over.
One other thing, just a small observation. Don't say that cancer-related deaths. Some sentence you have written there, pancreas, this, that. I think the history of a malignancy in the family is, I think, fair enough. Okay.
Yes.
It doesn't sound good, especially since he's a young patient. Yes, you are justified, because like a patient with a young patient with a carcinoma breast means, yes, so familial some kind of a, that's fine, but don't have to mention that way, right?
Yes.
And this of the hemoptysis and all for a patients with the this kind of a malignancies are too much imagination of tumor from abdomen going there into the lungs, causing hemoptysis. But before that, so many things will happen.
Yes.
If patient has got cough, you say cough, otherwise it's not required. Abdominal distension, yes. Why abdominal distension? Did you mention that?
No, sir.
Why? The more important, which you are not asked. First, talk about abdomen. What is the cause of abdominal distension?
It can be due to ascites.
So most common cause in malignancies,
Yes.
ascites. Any other distension is due to obstruction.
Obstruction. Yes.
So whatever it is. So these are more important rather than mentioning about the cough, all that hemoptysis, etc. Large liver also can give rise to upper abdominal distension.
Yes.
Female patient, large Krukenbergs can also give rise to abdominal distension.
Yes.
So this is how you try to tell that first before the lung, etc. Yeah, that's all, sir.
Shall you go for examination, sir?
Yeah, you go for it.
Yes. Coming to the general physical examination, the Karnofsky performance score was 80%. Patient is conscious oriented, moderately built and nourished. Pallor was present. No icterus, cyanosis, clubbing, or pedal edema. No generalized lymphadenopathy. Left supraclavicular fossa fullness was noted, which I'll be discussing later. Coming to the vitals, his pulse rate was 88 beats per minute with good volume, regular rhythm, which was measured in the right radial artery. BP was 110 by 80 mmHg in the right brachial artery in the supine position. Respiratory rate was 18 cycles per minute, and temperature, he was febrile. Coming to the per-abdomen examination, on inspection, a mass was noted in the right hypochondrium and epigastrium, extending approximately about 4 centimeters below the right costal margin, 2 centimeters left to the midline, 4 centimeters to the right of the midclavicular line, moves with respiration. Corresponding quadrants of the abdomen move equally with respiration. Umbilicus central inverted, no nodule or mass noted. No dilated veins over the abdomen, no visible peristalsis. Flanks were free, hernial orifices normal, and external genitalia normal. This is a short clip showing mass moving with respiration. Coming to the palpation, mass was palpable in the upper abdomen, occupying right hypochondrium and epigastrium. The inferior margin of the mass is 6 centimeters below the right costal margin in the midclavicular line, extending laterally up to the anterior axillary line. Medial margin is 2 centimeters beyond the midline on the left side. All borders are made out except the upper border. Mass moves with respiration. The surface was nodular with rounded borders. It was firm to hard in consistency, non-tender. Fingers cannot be insinuated between the mass and the costal margin. No other masses were felt. On percussion, the mass is dull to percuss with surrounding area which is resonant. Dullness of the mass was in continuous with the liver dullness starting from 5th intercostal space. Liver span is 16 centimeters. Remaining part of the abdomen is resonant. There was no evidence of free fluid. Auscultation, bowel sounds were heard. Examination of the back, there was no renal angle fullness, no tenderness, and no dullness noted. Per rectal examination, mucosa was normal, no growth, no blemish deposits. Melena was present. Coming to the examination of the left supraclavicular fossa, On inspection, there was obliteration of the space between the two heads of the sternocleidomastoid muscle on the left side. On turning the patient head towards right side, a swelling of size 3 into 3 centimeters, which was noted in the left supraclavicular fossa between the two heads of the sternocleidomastoid muscle. The swelling is firm in consistency, fixed and non-tender. The spine examination was normal. Systemic examination, CVS S1, S2 was heard. RS bilateral normal vesicular breath sounds heard. Coming to the summary of the case, here is a 34-year male presented with pain and mass in the right upper abdomen associated with passage of black colored stools, loss of appetite and weight. On examination, the mass is noted in the right hypochondrium and epigastrium with nodular surface, firm to hard in consistency, moves with respiration and fingers, cannot be insinuated between the costal margin and mass. Dull note over the mass and which is continuous with the dullness of the liver with left supraclavicular lymph node enlargement.
What is it?
Sir?
You have a single mass in the abdomen you are able to feel, or there are two masses are there?
No, sir, it was a single mass, sir.
So what do you think? What is that mass?
Sir, as coming with the examination findings, it was hepatomegaly, sir, because it was moving with respiration. Fingers were not, we couldn't insinuate between the costal margin and the mass. It was moving with respiration.
You make out upper border?
Upper border was not made out.
That point you have to take into your support.
Yes, sir.
What is your probable diagnosis?
So the surface was nodular with firm to hard in consistency, most probably secondaries in the liver with primary. It is mostly secondaries in the liver, sir. And with left supraclavicular lymph node enlargement, I want to keep the diagnosis of first as CA stomach.
What are the diseases in which you can find a supraclavicular lymph node enlarged?
In case of pancreatic malignancies, in case of carcinoma stomach, and in case of testicular tumors.
These are the three main common
Sir?
malignancies. So out of these three, you have to supposed to think of
Yes,
more.
sir. Yes.
So testis is ruled out because it cannot go to the liver.
Yes, sir.
So pancreas and stomach. These
Yes,
are the
sir.
two possibilities you are keeping.
Yes, sir.
How will you?
Pancreas, because there was no radiation of pain. There was no radiation of pain in the back, sir. So I.
Did you palpate the left axilla in this patient?
Yes, sir. Axilla palpation was normal, sir.
Why sir ask this?
Sir, to look for the iris nodules.
How the iris node is? What is the reason for iris node to be palpable in plastic stomach?
Due to the lymphatic drainage and obstruction, lateral thoracic veins, which drains into the axillary veins, due to that.
Hello.
Yes, sir.
Monik there? Yeah.
Yes, sir.
My question to you is, let us say if this patient does not have that melena or say early satiety,
Yes,
and it is I accept your diagnosis, secondaries in the liver.
Yes.
According to you, it's palpable in the right hypochondrium and the epigastrium.
Yes.
So, okay, what other things which you should have examined in this patient if melena were not to be there? He's a young patient. Please remember, he's only 37 or whatever.
Yes, sir.
I accept your diagnosis of secondaries in the liver. What other examination you should have done or you will do? Quick. Right?
In other words, sir is want to ask you where will you look for a symptomatology or examination for a primary?
So, and PR examination was normal, sir.
Okay, so you started by telling that stomach you are told already, we have discussed. Pancreas you have mentioned.
Yes,
Per
sir.
rectal examination, maximum you can reach the rectum. All right.
Yes.
Apart from, I'm just asking you clinically, what are the things you look in the whole body? I'm giving a clue now. Look whole body.
Genitalia examination was also normal.
More than genitalia, metastasis in the liver means anything in the leg, anything in the foot, very important.
Melanoma, sir.
So don't forget that, na?
Yes, sir.
You
Yes, sir.
need to remember there
Yes.
are few malignancies which you need to look for,
Yes,
which are possible. One toe may be absent there, one
Yes.
toe, and
Yes.
he may for him it is not important. So he might have not told you at all.
Yes, sir.
So you need to remember whenever there is a metastasis in the liver, especially once you rule out a GIT, 2 or 3 things which we have already discussed, these are the areas which you need to be more careful.
Yes,
Some
sir.
other things you can't even palpate, neuroendocrine tumors, so net, etc. So some of them are possible, but at least what your examination. So you mentioned about rectal examination for carcinoma rectum. Anything else you need to mention at this stage? That is the answer to my question only. Again,
Prostate, sir.
melanoma.
Prostate.
Can you get melanoma there?
Yes, sir. Rectal.
Where?
Anal melanoma.
Don't forget that pigmented skin there.
Yes,
It's
yes.
hidden.
Yes.
Whenever you have got a groin nodes, inguinal
Yes.
nodes, it's one of the important drainage areas. So that's
Yes.
what we would like to ask you. Otherwise, a liver mass, nodular mass, it is fairly straightforward diagnosis of a secondaries in the liver, right?
Yes.
So, did you look for splenomegaly, paralytic nodes, etc. in this patient?
Yes, sir. There was no any other masses palpable or splenomegaly was not there, sir.
So
If
be
you're supposed
specific. Sir?
If you're supposed to examine a para-aortic node, when will
Monica.
you palpate?
Yes, sir.
Where do you palpate for the para-aortic lymph nodes?
Monica.
Yes, sir.
Yeah, see, in the history, all the examiners were not accepting your first impression of primary from the stomach in a patient age 35 years. Shana
Yes.
sir was insisting that age is the strongest point against, even though he has got a few dyspeptic symptoms.
Yes, sir.
So when you presented, ultimately all of us are accepting that it is a liver mass with a nodular surface. All of us.
Yes, sir.
So when the diagnosis is asked, I think if we can stop at yes, it is a secondaries liver. We don't know the primary.
Yes.
We don't know the primary. Just because he has a melena and which cannot be explained by any means and dyspeptic symptoms, putting again in the final presentation, because in the history wise, none of us have accepted the CA stomach.
Yes, sir.
So after presentation, it is better if you stop it is probably a case of secondaries liver with a palpable left supraclavicular lymph node.
Yes.
What is a likely primary? Then you have to put vaguely. You cannot straight away again come back for the discussion of CA stomach. Shanai sir, this is what we insist upon for the students. Yes, sir.
That is fine, sir. So that is to open up their thinking capacity, sir. That is important here.
Yes.
So
yes.
If we
She has made up her mind for CA stomach.
Sir, that gets biasment will be there, sir, because the candidates have worked on the same type of cases that is usually there. So now my question to you is, if it is stomach, where is the lesion? Because you said it's not at all palpable. Where is the lesion? That is my question to you now.
Can be in the body of the stomach, sir.
But you are not you are not able to palpate in your examination at what the sir is asking.
No,
That's
sir.
the same question I asked in the history part also.
Yes, sir. If it is in the body of the stomach, usually it won't be palpable.
No. Don't make that statement.
Body will be palpable.
If patient has lost weight and body means, and our manual labor worker, you can easily palpate. What you can't palpate is probably under the costal margin will be the higher up lesions. Fundus, that area. More greater curvature, greater curvature side, high up lesion. Right?
Yeah.
If it is very close to the G junction, you would have had a dysphagia. Does your patient dysphagia is there?
No, sir.
No. So do you think it's pyloric antral lesion because of the liver you can't feel? The large liver is there according to you. So I can't feel the pyloric antrum. Is it possible in your case?
So, but obstruction features of vomiting and all are not there, sir.
Yes.
So that is how you should tell in the exam, sir. Most probably it is unlikely. See,
Yes.
in the clinical exam, nothing like it is impossible. So what you
Yes.
can do is, it will never be a total obstruction sometimes.
Yes.
Less likely because
Yes.
the patient does not have a vomiting, or this is a time they may expect you. Did you check for any visible gastric
Gastric
peristalsis?
peristalsis.
Your
Yes.
answer could be patient has no vomiting, so I have not checked. That is
Yes.
fair.
Yes.
Any other questions, sir? That's all from my side.
Okay. How will you proceed further?
So, coming to the investigation part, sir, I would do routine investigations, ultrasound, to confirm my diagnosis. As an extension of my clinical examination, I would do the ultrasound, sir, to see as I have diagnosed it as a hepatomegaly, sir. Second is in liver. I want to see the status of the liver, sir.
Okay. Only liver?
Liver, and I want to see whether ascites is present or any dilated stomach is present.
As it has been told many times, that's fine, routine is okay. But when a patient has come to you,
yes,
better you can easily straight away say ultrasound. Ultrasound, even if your hemoglobin is 3 grams, you can do, no issues. So that will, how does ultrasound will guide you in your patient to direct the next investigation
Investigation. So
that you tell me.
So I want to confirm whether through ultrasound whether the liver mass is from primary or a secondary, sir. By the echo, by seeing the echogenicity of the liver, not with hypodense, hypoechoic or hyperechoic lesions, with altered texture of the liver, and with ascites, or with any nodal involvement.
see, when you are
Yes, sir.
when you are ordering for ultrasonography, your basic purpose is to see whether it is a solitary, single, or multiple metastasis are there or not.
Yes, sir.
Whether it is a unilobe enlargement
Or bilobe
enlargement.
Yes, sir.
These are having a very much bearing on your further investigation and management. Right?
Yes, yes.
These are the things you should keep in mind.
Yes, sir.
Second thing is, does it have affected any biliary channels at any level? So
Yes,
these are the few of the things which you have to ask your radiologist very specifically on ultrasound, rather than to go for here and there.
Yes.
And second thing is umbilication. If it is umbilication,
central necrosis.
Yeah, central necrosis, that is more favors which kind of a pathologist?
Secondaries.
Within the histological classification, if there is a central umbilication, that more favors of the adenocarcinomas.
Yes, sir.
So if you ask that thing, most of the so many things will be cleared in your line.
Yes, sir.
Anyone can add, sir.
Do you have the ultrasound reports with you?
Yes, sir.
Can you just first put that at least picture or report or something? Yes.
Moderately enlarged liver showing multiple variable sized well-defined heterogeneous lesions are noted in both the lobes. Largest measuring 7.4 into 6.1 centimeters, showing vascularity on color Doppler, suggestive of neoplastic lesions, malignancy, query metastasis.
Just for the sake of what are the primaries normally produce big bulky metastasis in the liver? In your case, actually, they are very big ones, 7.4 into
7.1, yes. It is a true.
Which are the few large, bulky? We call as a bulky metastasis.
Usually, colorectal malignancies will produce bulky metastasis, sir.
But any other possibilities?
Any other? Large secondaries then. Large secondaries.
Yes, just now you said something. Yes.
Carcinoma, gallbladder carcinomas.
No. Like
earlier
that.
Earlier you discussed.
Melanomas.
And yes, and even a
carcinoid tumors, sir.
Carcinoids
Yes.
also, melanomas,
Yes.
especially colloid carcinoma, rectum, they can give a bulky, big metastasis, large ones.
Yes.
So like that. Yeah. Yes. Next, what is the next investigation you have done after this report?
So I have gone with the CCT abdomen pelvis, sir.
At this stage, when the ultrasound has shown you like this, did you get the endoscopy done? That's
Yes,
what I
sir.
would like to ask you.
Yes, sir. Endoscopy was done, sir. It showed an ulceroproliferative growth noted at 39 centimeters from the incisors, involving the OG junction fundus of the stomach, sir.
So that is what we were talking to you. Why though you didn't feel the stomach mass? Maybe because
Yes,
of the very high lesion. Only thing is dysphagia part.
Yes,
I don't
sir.
know whether you missed that dysphagia. I do not know. But you said early satiety. Now you know satiety is because of this large liver rather than the stomach. Stomach is not involved much. Stomach is not involved in this patient much.
Yes.
So.
And early satiety, basically, now if you can retrospectively ask the questions whether the patient is having a fullness in the chest after the little meal, then you will have a little bit more idea for this all the things.
Yes.
Early satiety is not explained exclusively what is the reason.
Yes.
And rather than early satiety, if you said there is a dysphagia, patient eats little bit and then is not like to eat. So that is maybe because of the esophageal fullness. So there may be some interpretation problem in patient and you. That's what I feel. Otherwise, OG junction pathologist, particularly ulceroproliferative, usually gives the dyspeptic symptom if there is such a big metastasis in the liver.
Yes, sir.
Okay, fine.
Why did you carry out the CT scan in this patient? What was the purpose of carrying the CT scan?
Yes.
Sir,
Is there any indication of getting CT in this patient for the treatment point of view?
no, sir. It is already advanced and it has spread everywhere, so there is no point. For treatment purpose, there is no use of CCT abdomen.
Did you carry out the FNAC from the? Did you carry out the FNAC from the cervical lymph node?
Yes, sir.
Lymph node?
Yes, sir. It showed a moderate to poorly differentiated adenocarcinoma deposits in the left supraclavicular region.
So what we probably expect is that no doubt routine you will do blood because hemoglobin will be lower, whatever it is.
Yes, sir.
Ultrasound, definitely extension of the surgical. That's what we said, arm or something.
Yes.
That has added you. Metastasis is there in the liver. It has picked up no other lesion.
Yes,
so now,
sir.
I think endoscopy should have done next. Ultrasound and endoscopy.
Yes.
In your patient, if the supraclavicular node is such a big and palpable, yes, you could have already hit the diagnosis here only.
Yes.
FNAC has already proved the diagnosis.
Yes.
And endoscopic biopsy, yes, that will confirm your diagnosis.
Yes.
In your patient, I don't know whether the CT scan is required or not. I do not know. Khanna sir, what is your feeling here? For
Yeah, that is what I was asking, that why the CT was done in this patient.
Because of extensive metastasis is already there in the liver. All right. So now we'll put a question in a little different way, that that if the liver is normal and if this is the biopsy and supraclavicular node is not palpable, what will be your further management or further discussion?
How to go ahead?
Yes.
So depending on the location of the tumor, sir.
It is located at the esophageal GE junction.
You already know it is 39 centimeter, and we have put we have mentioned no metastasis and no supraclavicular node.
Yes. Sir, in that we have to know whether it is type based on the classification of CVET classification or for type 1, type 2 and type 3, sir. We have to know whether it is invading into the esophageal extension into the esophagus and gastric cancer. We have to make a definitive diagnosis. Usually for the OG junction tumors and the proximal gastric tumors, we go for total gastrectomy with esophageal sir, with adjuvant chemotherapy.
This esophago G junction, you said 39 centimeter, and fundus, you go for a total gastrectomy and total esophagectomy, is it? Is
Yes,
this
sir.
the one in your patient?
Yes, sir.
You are going to take out the entire stomach and the liver. Then how are you going to reconstruct this?
Sir, esophagogynostomy.
No, I'm little confused. You said no, just now total esophagectomy and total gastric.
No, sir, total gastrectomy with lymph node dissection with total gastrectomy with esophagogynostomy, sir.
Why you want to do a total gastrectomy in this patient?
Sir, usually the type 3 is tumors of severe classification. We go, the better is for, because distally, distal involvement, submucosal spread, if it is there, if we can give adequate margin, then we can go, sir. We can give proximal gastrectomy, sir, superior pole gastrectomy, sir.
I think as Dr. Raj Gopal is saying that probably you will be more happy with the partial gastrectomy here.
Yes, sir. Partial.
We can make it.
Partial
We can either do.
The CVET 3, there is still controversy. Total gastrectomy versus partial gastrectomy. Probably in Indian setup, we have a lot of bulky tumors. Usually, some centers routinely recommend total gastrectomy is standard care. But your partial gastrectomy is still acceptable because it is a controversial part. It's Stewart type 3.
How big is this tumor on endoscopy? What is the size of the tumor which is there on endoscopy?
Sir, it was around 4 into 3 centimeters, sir, extending from junction to the fundic region, sir.
So it is 4 centimeter is there at the, which is 39 centimeter from the incisor. So
yes.
I'm not sure that
exactly.
We should.
I think Kanakvel probably will. Kanakvel will give his expert for
I think you can give a better answer.
How much fundus is involved here in the this one?
It was on just around 2 to 3 centimeters of the fundus. It was not complete involvement, sir. Growth was around up to 3 centimeters, sir.
Is there any role? Is there any role of EUS?
Sir, usually it is useful in case of early gastric cancer, sir, to see the T1 involvement of T1A and T1B with whether submucosal involvement is there or no, sir. In case of early gastric cancer, it is useful, sir. And to perigastric nodal, to see the perigastric nodal involvement, EUS is useful, sir.
Dr.
Now
Monica.
tell what can we do for this patient here? Can we give some treatment to this patient?
So only palliative treatment we can go for chemotherapy, sir. But apart from that, in order if he goes for any obstruction or complication, then only for the quality of life we can go for partial gastrectomy, which gives his proximal gastrectomy, sir.
Sure.
Any other alternative
Short of
method?
partial gastrectomy, can we give some palliation here? If there is a growth at the esophagogastric junction is there, any alternative treatment for that? Yeah.
Stenting can be done, sir.
Yeah. In these patients where the life expectancy is less,
yes, sir.
Patient is having a huge metastasis with the left supraclavicular node.
Yes, sir.
You can put a metallic stent there. That will, if it is obstructed, till the obstruction doesn't develop, you will not go for that kind of a thing. Patient is having a dysphagia and not able to pass anything.
Yes,
at that junction you have to intervene, not before that.
Yes.
Otherwise, we'll give a wastage of time and tumor will infiltrate within the stent itself.
Yes.
Can we use some energy source there to channelize the food channel?
Sir?
Any other alternative therapy, sir, is asking. Alternative therapy. Energy source is asking.
Ablations. Radio frequency.
Laser is, is the
laser.
You can use the ND-YAG laser for that.
Yes, sir.
So that you at least you open the channel for the food.
Yes, sir.
So one or two questions probably in this patient, of course, clinically, palliation only is the thing which will be asked to you here. About the pain relief is the only one thing which you need to do. And
Yes.
patient has got a supraclavicular node, and I do not know the actual survival, whether what chemotherapy is given in your institution, whether it's really worth or something like that. But otherwise, two situations, if it is only G junction, that 39 centimeter, stomach is normal, what you would have done? We'll put it that way first, clarify one by one. Stomach is not involved. Supraclavicular node is not there. You had an endoscopy, there's a growth. What will you do?
Sir, if stomach is not involved, then we have to go for Ivor-Lewis procedure. We can do Ivor-Lewis procedure, sir.
Ivor-Lewis procedure is, what is the advantage of Ivor-Lewis over transhiatal esophagectomy over three-field esophagectomy? 2 or 3 questions, you just quickly tell.
Yes, sir. In case of Ivor-Lewis, we go for intrathoracic anastomosis, sir. So the chance of leakage will be more, sir.
In your institution in the recent times, have you seen Ivor-Lewis operation? How
No.
frequently it's done? No,
No,
not.
sir.
What's the advantage of transhiatal esophagectomy? What is the name of that? What is the name given to that?
Oringa's procedure, sir.
What's the advantage?
Um,
Advantage. How many anastomosis and where is the anastomosis?
Sir, it is the anastomosis in the cervical region, sir, in transhiatal.
What's the disadvantage? So you are not opening the chest?
Yes, sir. Because we are blind, there will be blind dissection, sir. There will be chance of azygous vein.
Maybe lymph nodal clearance.
What you leave behind? What you leave behind, which will not do in the transaction?
Complete lymph node resection won't be possible.
So
adequate lymphadenectomy is not possible in transaction.
Not possible. The good retractors, what originally described, good retractors, who don't even call it as a blind, it is possible, but you need to have a good retractors for that. Dr. Kanakavelu, please give your opinion about this case, about related to the stomach involvement, and what is this gastrectomy to be done here, or what is?
Sir, let me first very clearly agree with all the faculty. This patient, it is only palliation.
Correct. That is over.
Type 1 as Seward's type 1 or type 2. Now it is anatomical supra Z line and below Z line. Both the Japanese and American policies are different. Students, please note, these are all advances for you to learn. In exam, if you are going to tell total gastrectomy with adequate proximal margin of 5 centimeter of esophagus, you are justified. People may believe if you are doing only a cleaning resection, mucosal negative margins of esophagus is fine. Because in this patient, whatever you do is only to palliate. Please understand, don't offer surgery in this patient. Very clear. Very clearly, it should be palliation in some format by the way of stenting to alleviate dysphagia, and other form of pain relief is the solution. Yet another thing you should be knowledgeable in knowing is only one trial in gastric cancer metastasectomy, the finished trial, which also has a very short list. 64 patients only have been undergone metastasectomy or hepatectomy for cancer stomach. That center is alone showing reasonable increase in survival, whereas no other center in the world are able to prove benefit for metastasectomy or hepatectomy for gastric cancer. So for all reasons, there is no indication for hepatectomy for the benefit of the students. The other effective palliation is, I am sure students should be aware of the TOGA trial. TOGA trial is the named trial, which is the use of trastuzumab for metastatic gastric cancer. Again, please be aware, there is increased survival after using monoclonal antibody. We are not aiming for cure. Increased survival reported are 90 to 120 days more is the mean average of increased survival. We don't talk about years also, but then the disease can be kept in abeyance. That is the message given by the TOGA trial. TOGA trial, for using trastuzumab, the tumor should express epidermal growth factor receptor, EGFR. If they are positive in expressing this, then you can consider for this patient. That is the only indication for monoclonal antibody at this point of time. The other drug which is being accepted and NCCN has concurred is the ramucirumab. See, a genetic profiling of the tumor can be helpful. Then the other newer monoclonal antibody which are come as the pentaxin or the neuropentaxin or NTPXR. Please be aware, this is only for recent advances. They are not effectively come as patient trial or beneficial patient benefit or anything. See, other things are the NPTXR or neuronal pentraxin receptors. All other things are for you to write recent advances, not to tell in the exam. So the point is, message is very clear. Monoclonal antibody to prolong the survival. Standard conventional chemotherapy. Here, one other thing you should be aware is radiation therapy for disease control is also a potential option. These are the things you should be able to tell when your examiner tells how do you manage. Coming to the point of either proximal gastrectomy or a total gastrectomy, the proponents of proximal gastrectomy, at least in our experience and whatever we have done, patient end up having severe reflux. The quality of life is much lesser and the patients may need to be supplemented with ursodeoxycholic acid with double dose pantoprazole with prokinetics, and it becomes miserable because patient need to have couple of pillows to lie down every night to sleep. On that way, I agree with the people proponents who end up telling total gastrectomy through on by esophagogynostomy. This way there is no reflex, and more so when the presence of, especially if planning for radiation therapy and other things, leaving a refluxing esophagus is all the more troublesome. Adding to the radiation, these patients end up having more symptomatology and the quality of life significantly comes down. So for
one more remnant you are leaving behind, the remnant gastric remnants, sir, lower on. There can be again a potential source for malignancy. That is also one justified for the total gastrectomy.
Sir, it again depends. If you expect the survival to be more than 1 year, then you talk about some form of extended radical or radical surgery. At this point of time, D2, regional D2 is the optimal lymph node dissection which is being accepted by the international community.
Yes, sir.
Anything else to be added, Shania, sir?
Nothing. I just wanted those points to be clarified. That is because generally in this patient is only palliation will come, but examiner will ask you no lymph nodes, nothing, say operable tumor. You have done the CT scan, then what you have done. So now it's very clear that it's going to the stomach. I think the total gastrectomy with the esophagus means it has to be in the Iver-Lewis type only. It will be the thoracic anastomosis. Correct?
Yes, sir. At this point, please be aware, one question Dr. Shania sir asked, you didn't answer. Yes. How will you reconstruct after total gastrectomy and total esophagectomy? The only option what you're left with
colonic
is
colonic
right?
interposition.
For a patient with liver metastasis, it is again surgical ethics to consider a colon replacement for these patients. So, yes. if you are happening to do a extended esophagogastrectomy, you can do a free jejunal grafting up till 30 centimeters in effective free jejunal graft you can do. But then you need expertise from your microvascular surgeon because free jejunal graft definitely needs some form of revascularization with the regional vessel, of which colon seems to be a more pliable and plausible option because the advantage is colon can come up till the neck or up till the pharynx also without much of a trouble. But not for this patient, please be aware.
Yes.
Yes.
The bridging of proximal gastric resection can be segmental jejunum, segmental colon for proximal gastrectomy. For total gastrectomy, esophagogynostomy. For esophagogastrectomy, again Roux-en-Y esophagogynostomy. For subtotal esophagectomy and total gastrectomy, colon is the optimal choice, where colon is not cannot be used for various inflammatory reasons, especially in India. Then you can, the optimal choice is right colon, second optimal choice is transverse colon, third choice is the left colon. people, as you know, why I'm telling, their technical is, this is the order of priority, and isoperistaltic colon is the optimal choice. Antiperistaltic colon will be, sometimes you end up having troubled patient all through. So for all reasons, right colon replacement, isoperistaltic is the right solution for colon replacement. Faculty, please take over.
I think she
Yes,
has
sir.
done well, she has done well, but only thing is you need to know that young patient means don't get biased and straight away say carcinoma stomach. That's another thing you should know. So you start that it could be a liver mass, no doubt. Then you think of, sir, 1 or 2, 3 possibilities I would like to consider. This is how you take off. So that and you need to also explain the melena and satiety can be due to other factors. This is how you need to know. And clinical diagnosis should be totally unbiased, in the sense, based on your finding, you give a diagnosis. That's all. Then one or 2, 3 possibilities, and you start that. Further, based on the investigation finding, you should immediately examine, ask you, what do you expect in a biopsy? So you need to know the little bit of histology also. Adenocarcinomas. This 3 means it should be more behaves like a stomach type. It is more of a stomach type. So you need to treat it that way. So like that, what is the advantage of CT scan? What is the advantage of transhiatal? So 1 or 2, 3, these are common questions you need to expect. So that's all, sir.
Thank you, sir. Thank you. Kanna sir, anything you would like to add, sir?
I think everything has been discussed
Thank you,
nicely about this. Yeah, there is no doubt this is a case only for the palliation, not for any other thing.
Monica, you have any doubts, Monica?
No, sir.
Thank you. Thank you, Monica. Thank you,
Thank you,
faculty. Rajan, sir, your closing comments, sir.
Yes, sir. Thank you, sir. Thank you for your invitation. And both of the candidates have done well. They have presented the thing. And there are lots of learning is there. I will be happy to join again for further discussions in the future.
Rajan Patel, sir, your chessboard from Greece looks like it is very good. Chessboard.
Yeah, sir. Basically, it is a Zoom. My daughter is playing a chess. She is an international player.
Oh,
lovely.
She's 13 years. She has a Commonwealth Championship and Asian Championships.
Sir, I am also a small time player.
So she keeps her, because we are sharing the Zoom for her learning and the same platform. So she keeps that logo.
What's the name, sir? Name?
Riddhi Patel.
Okay. I hope she'll become like Konero Hampi. Okay, sir.
Grandmaster.
No. Our this year, because of problem of COVID, we are not able to travel anywhere, and so now her inclination has started towards study from the chess.
Oh.
Yes.
Right, sir.
Okay.
Right.
Thank you, Kanadwar sir, for opportunity. Thank you, Shanesh sir.
Happy Christmas to all.
Happy New Year.
Thank you,
Happy Christmas to all.
Happy New Year. Happy New Year.
Thank you, Monica, and thank you, Rasa.
Happy Christmas to everyone. Happy New Year. We'll meet in a new year.
Thank you, sir. Thank you. With the permission of the faculty, now I